Welcome back. Uh, Today we are continuing on physiotherapy techniques to clear the secretions. Okay, so from the background that we have laid, we've discussed a number of interventions. We've discussed the full assessment that is required to do for you to carry out, the full assessment that is supposed to be done for you to ascertain the extent of problem that your client has. So continuing, we are looking at physiotherapy techniques to clear secretions. Okay, so we are starting with, basically we are looking at respiratory physiotherapy. So amongst them is what is referred to as chest physiotherapy, which is a term for a group of treatments designed, okay, designed to eliminate secretions, thus helps to decrease the work of breathing. So we know that with blockages in the airway secretion, the labor of breathing becomes the work of breathing actually becomes very high, and that is not normal. It has to be reduced. So this is now where you come in and do your respiratory physiotherapy. Okay, so you are going to do this in order to promote lung expansion, prevent lungs from collapse, amongst other aims, other indications. Okay, this chest physiotherapy is a bit different from bronchial hygiene, which is actually like an umbrella term. Okay, bronchial hygiene is actually an umbrella term because it incorporates the same chest physiotherapy that we're talking about, along with breathing exercises and manual hyperventilation in an intubated patient. So it brings in all these other techniques because in bronchial hygiene, there is an involvement, okay, of non-invasive airway clearance techniques designed to help mobilize and remove secretions and improve gas exchange in the lungs. So we know this is the main idea here is to clear the airway and decrease the work of breathing. Therefore, chest physiotherapy is an important adjuvant treatment of most respiratory illnesses, from chronic respiratory illnesses. So amongst the illnesses that are common in which chest physiotherapy is indicated are COPDs, neuromuscular diseases, COPD such as bronchiectasis, and amongst bronchiectasis, bronchitis, cystic fibrosis, amongst others, which we are going to talk about later on. Neuromuscular diseases as well, okay, which include cerebral palsy, spinal cord injuries. All those may depress the normal function of the respiratory system, and chest physiotherapy will be indicated, as well as in perioperative care, mainly in the upper abdominal surgeries. Chest physiotherapy is also a valuable component of comprehensive respiratory care. Okay. The purpose of chest physiotherapy are number one, to facilitate the removal of retained or profuse airway secretions, to optimize lung compliance and prevent it from collapsing, to decrease the work of breathing, as well as to optimize the ventilation perfusion ratio. You remember we were talking about dead space in our previous discussions. We were talking about dead space. So we are saying the dead space has to be reduced. If the dead space is increased, that means the space for gaseous exchange is also reduced. When the dead space is reduced, we have more space for ventilation, perfusion exchange. Okay, so dead space has to be reduced to optimize the ventilation perfusion ratio. So before we continue with the chest physiotherapy and how it is done, let's just have a short talk about the normal chest clearance. How is the normal physiological clearance of the chest? How does it happen? Okay, so the normal clearance, a normal clearance requires an open airway, a functional mucociliary escalator, and an effective cough. So in the normal lining of the airway, which is lined with about a 5 micrometers layer of the mucosal membrane, therein lies what is known as cilia. So cilia actually helps to move secretions from up, I mean from deep down in the respiratory tract up for expectoration or to be spat out. So the ciliated epithelium lines the airways, responsible for the continuous flow of mucus over the airways, over the airway surface to the upper respiratory tract. This mucus is moved via coordinated movement of the cilia motion towards the trachea, the larynx, and where excess secretion can be swallowed or expectorated. So that happens normally and continuously during the day. We swallow a lot of secretions, and if it is too much, we even expectorate. The effective cough is a must for normal clearance, as cough is one of the most important protective reflexes. Okay. It rids the larger airways of excess mucus and foreign matter. The cough assists the normal mucociliary clearance and helps ensure airway patency. So for all this process to be physiologically sound, this has to be in place. There has to be a normal mucociliary function working on a lining which is at least around 5 micrometer thickness, so that cilia can move effectively and clearly move secretions from the deep down the respiratory tract up for expectoration. Then when it goes onto the surfaces where it can trigger a cough reflex, the reflex is triggered and cough comes in, and we have coughing, and then we can manage to cough up the sputum or the excess secretions. So this cough reflex comes in 4 phases. In the first place, following irritation, following excess secretion and following bringing this cough or this cough coming towards an area which is sensitive, a reflex activity is triggered, which will follow the sequence of number 1, irritation. Okay, so irritation will be caused. Then suddenly after irritation, there's going to be a sudden inspiration. After inspiration, there's going to be compression, and finally expulsion. So these are the phases of a normal cough. So this cough, again, due to some maybe diseases which we have already named, like the COPD diseases, some of the things that can arise would be that the cough may not be that effective. So you need to facilitate that cough or a huff. So in facilitating a cough, you can actually tell your patients to be in a seated position, as you can see in the picture that we have there. Okay, we can see that your feet, the patient's feet are supposed to be both of them down, patient comfortably seated in that way. Okay, leaning forward a bit, and tell them to take in a slow, deep breath, okay, through the nose, and hold the breath on a count of 2. So the holding of the breath is like you're pushing air down, breathe in deeply and hold the breath, okay, for a count of 2, then breathe out. Okay, so the breathing in, that air that has been pushed in is like now opening up the deeper structures of the airways, and sticking the the mucus or the secretions that are there, so that they become loose, and now this patient breathes out. After the holding in, make sure that there is inflation on the distal end of the airways. So at the end of it, you tell them to breathe out. At the end of the breath, tell them to force the cough at least twice. So there should be a short cough at least twice. So by so doing, secretions are being pushed from the deepest end of the airways onto the central zone, where the cough reflex can now be triggered. A normal physiological cough reflex can be triggered so that secretions are moved. At this point, you are facilitating so that there is this collection of, through this breath, through this technique, there is the collection of secretions from the deepest end onto the central zone so that it can be coughed up. And by so doing, you are clearing the air. The same technique can happen on which you do almost the same things that we have already discussed in the cough, in the facilitation of cough, only that at the end of the breathing out, you tell the patient to huff, okay? They huff as though they are trying to clean glasses. That sound they make, the complete breathing out, which they make when they are trying to clean glasses. So that one, they do it after breathing in, hold the breath, then breathe out completely. Then at the end of the breathing out, they huff as if they're trying to clean glasses or trying to clean the mirror. Then by so doing, slowly, you are correcting or you are trying to push up the secretions from the deepest end onto the central zone. Then at the end of the day, the cough reflex will have been triggered. Okay, so we've looked at the normal clearance and the facilitation thereof. Now let's also look at the abnormal clearance. Since the cilia is meant to work on a lumen, okay, on a lining that is about 5 micrometers, disease can fall in and it can make this lining to become thick, okay? Some bronchial diseases would cause the mucus layer to exceed about 5 millimeters of thickness, and ciliary clearance becomes ineffective as the cilia, physiologically, it cannot move on such a thick lining, okay? Therefore, forced expiratory techniques in this situation were introduced to solve this problem. And if cilia does not physiologically move, it means there is a stasis of secretions and there is accumulation of secretions in the airway, hence increasing the labor of breathing and making it difficult for gaseous exchange to occur, bringing in a lot of other respiratory complications. Therefore, you need to come in to solve this problem. And hence the techniques that are known as forced expiratory techniques. Okay. There are various physiotherapy treatments incorporated within this chest physiotherapy that we are talking about. Amongst them are what are classified as the conventional techniques, as well as the modern and instrumental techniques. Those that are known as conventional techniques are also referred to as traditional chest physiotherapy. Okay, meaning the old way of treating these problems. As we are aware, research is is ongoing. Research on actually everything is ongoing, and everywhere there is research going on, and there is continuous improvement and re-evaluation of the knowledge that has been known and practiced all along. Okay, so the odd one involves manual handling techniques to facilitate mucociliary clearance, which include postural drainage, along with percussion and vibration. Okay, which were previously named as chest physiotherapy. Later, coughing exercise, and forced expiratory techniques were incorporated. Therefore, postural drainage, percussions, and vibration with huffing have shown that they give out an effective outcome. So there is this combination. There is a tendency we have in physiotherapy of referring to postural drainage, to all these other techniques that I've added in, which is exercise, coughing exercises, as well as percussions and vibrations. These are not the same. Postural drainage is just the positioning techniques. Okay, so let's learn to separate these. This combination works better if applied with a bronchodilator therapy, which we are going to talk about, where you add the bronchodilators. Okay, they dilate the bronchi, they also loosen the secretions. Then now you come in with these combinations. So postural drainage involves the positioning of the client with the assistance of gravity to aid the normal airway clearance mechanism. So in postural drainage, you are just positioning. the client in different positions according to the need that you will have arrived at following your thorough assessment, which we talked about in patient examination, both physical and subjective and objective assessment. Then you will get to know exactly what the patient's problem is. Then now you institute this technique. Postural drainage position varies based on specific segment of the lungs with a large amount of secretions. So you are going to check from your assessment, you will see which one has large amount of secretions or which one has secretions. And that is the one that you're going to drain. This comes with the knowledge of the bronchial tree. Okay, you have to go through the bronchial tree. You have to understand it. That one was done in physiology, as well as in our first lecture, we talked about the bronchial tree. So that knowledge supposed to be applied here, so that you apply it here and make sure that you have a comprehensive understanding of what is being discussed. Postural drainage is the drainage of secretions by the effect of gravity from one or more lung segments to the central airways, where they can be moved by cough or mechanical aspiration. So your aim is to move secretions from the distal ends to the central zone so that they can be removed either mechanically or by a cough reflex, like what we just discussed earlier on, where you are bringing into the central zone so that a cough reflex can be triggered and a normal cough can come out and clear the air. Therefore, each position consists of placing the target lung segment superior to the carinae. So the carinae is the area that is in between, where the trachea bifurcates into the bronchi. In between there is what is referred to as a carinae. So revisit your bronchial tree and you find that where the trachea comes in, there is the point where they bifurcate into the bronchioles. At the central point there, that is where that is the point which is referred to as the carinae. So that point is very sensitive and it triggers very strong cough reflexes, and that is the aim for postural drainage. Once they are drained, secretions are drained, they get to the carinae, the strong cough reflex are triggered, and the airway is cleared. Okay, positions should generally be held for about 3 to 15 minutes, longer in special situations, as well as standard positions are modified as the patient's condition and tolerance warrant. So you should have the knowledge of auscultation. Okay, you should be able to auscultate, know the bronchial sounds, know where the normal and the abnormal, so that you know which segment needs to be drained. Okay, it can be facilitated with percussions and the vibrations in the postural drainage position. So you put the patient in a postural drainage position, then you do your percussions as well as the vibrations. So postural drainage is basically about positioning. So if you are given to drain a certain line segment, then you position wrongly, it means you are not treating that segment. It means you are actually doing a wrong thing. So this is a must know. You have to know these segments. Okay. So as we can see from the pictures that we have here, which are specifying what you are supposed to do at each point. For the upper lobes, apical segment, okay, you position your patient as such because the apical segments are there. Okay, the upper lobes posterior segments are there. Okay, you use postural drainage on them. Okay, you use postural drainage on those. Okay. Yeah, so this simply means these positions have to follow the area that you have identified to have a problem, and position has to be accurate so that when you do your manipulations, your techniques, you apply your techniques, you're actually doing it right, and it will exert a beneficial effect on the patient. Do not waste the patient's time by treating the area which has no problem. So these are the positions. We basically have up to 10 positions, and they are must know for each segment, as I've already alluded to. If you position wrongly, it means you are not responding to the right question. You are treating a wrong part, which the patient is not complaining about. Percussions are also referred to as cupping, clapping, and the apportments, which are part of the massage techniques which we discussed. These are supposed to be part of the postural drainage. So in those postural drainage positions, you do these techniques. The purpose of percussions is to intermittently apply kinetic energy to the chest wall and lungs. Okay, this is accomplished by rhythmically striking the thorax with a cupped hand or mechanical device directly over the lung segment being drained, so that you loosen the secretions and send or allow the secretions to be drained to the central zone. That is the whole essence of whatever we are discussing, is to loosen the secretions, allow them to be drained to the central zone so that they can be coughed up. Okay. Vibrations involve the application of a fine tremulous action, okay, over the draining area. This also does the same. By vibrating, you are loosening the secretions and you are allowing for the secretions to come to the central zone. So we've said these techniques are coupled with breathing exercises, okay, postural drainage, vibrations, percussions, as well as breathing exercises. So as you loosen these secretions, and remember we also said it is performed better with the aid of bronchodilators. So when you put together all those, secretions will loosen, and at the end of the day with breathing exercises, we'll bring them to the central zone with forced expiratory techniques also being taught, then the person will cough up, okay? And yeah, the person will cough up and the secretions will come out, thereby achieving the aims that we want. So these are the combination. We have the coughing, which we've already discussed, forced expiratory techniques, okay, which involve diaphragmatic inspiration, relaxing of the scapulohumeral region, and expiring forcibly from the low lying volumes, okay, whilst maintaining an open glottis, what we discussed in huffing and in facilitation of coughing. That is what is encompassed in forced expiratory techniques. Indication of conventional techniques, postural drainage, include inability to or reluctance of the patient to change positions, poor oxygenation, okay, associated with position, potential for the presence of atelectasis and presence of artificial airways. The combination of postural drainage, percussions, and vibrations, the indications are when the patient has difficult clearing secretions with expectorated sputum production greater than 25 to 30 mL per day in an adult. Evidence or suggestion of retained secretions in the presence of an artificial airway, presence of atelectasis, presence of a foreign body in the airway, as well as patients with copious sputum or with central consolidation. This will call for a combination of postural drainage, percussions, and vibrations to be instituted. However, there are some contraindications that come with these techniques, the conventional techniques. The overall one, we have that all positions are contraindicated for intracranial pressure, which is greater than 20 millimeters of mercury. Head and neck injury, postural drainage is contraindicated. Active hemorrhage, recent spinal cord injury, acute spinal injury, as well as empyema amongst a number of others. Okay. Bronchopleural fistula, large pleural effusions, rib fracture, all these are contraindicated. They are not supposed to be done. Okay. Frequency. Frequency of the position, how frequent do you position your patient in these postural drainage positions. Ventilated and critically ill patients as necessary with the goal, okay? of once each hour or every hour as tolerated around the clock. Less acute patients should be turned every 2 hours or tolerated. So in other words, this is now dependent on your assessment, okay? This is now dependent on your assessment. So you are going to assess, evaluate, and know that this patient at least can tolerate 2 hours, 3 hours, 4 hours, depending on the condition of your patient. This order, postal drainage therapy order, should be re-evaluated at every 48 hours based on the assessment from individual treatments. In simultaneously breathing, spontaneous breathing patients, frequency should be determined by assessing patient's response to therapy. So in other words, you have the autonomy to actually decide, depending on the patient's condition, you have you actually tell to say that we are going to do it for this number of hours. And of course, increase in the duration would mean there is an improvement. So you need those constant evaluations. So that is about modern techniques. I mean, that is about conventional techniques, also referred to as traditional techniques. The second one we said is referred to as modern techniques. Over the years, several additional non-invasive clearance methods have been developed to augment this traditional approach. Nothing is being thrown out, but research has been, as we already mentioned, that research is ongoing. So a lot of other techniques are coming in. Modern techniques use a variation of flow through breath control to mobilize secretions. It includes acute cycle of breathing and the autogenic drainage. Okay, so acute cycle of breathing, also referred to as ACBT, can be used to mobilize and clear excess pulmonary secretions and to generally improve lung function. It has a series of phases which include number one, breathing control, thoracic expansion, and the forced expiratory techniques, okay, where you instruct your patient. So at the end of the day, you will notice that they are almost going to the same mechanism that we have discussed. Like for instance, in SCBT, you instruct the patient to take 3 deep breaths, holding each breath for about 3 seconds if you can. Take a normal sized breath in, followed by a half, as if trying to steam up the mirror. So this also goes to the same where you breathe in, tell them to hold so that they unstick, they hyperventilate the areas that are clogging so that the sputum is corrected and then coughed up. So this is a series of SCBT. They are used to clear the airways. Then there is also what is referred to as autogenic drainage. Under autogenic drainage, it also has 3 phases. Okay, active breathing technique using high expiratory flow rates and variable lung volume to unstick, collect, and evacuate secretions. So these are the main terms actually that have been used almost in all the other techniques. To unstick, the mucus that has collected, it is sticking inside there and closing up the smaller airways. So you need to unstick them by breathing in, hold, okay? By holding it open, you are unsticking, then collect by forcefully breathing out, then now you evacuate by forced expiratory techniques. So it is in a similar way. The goal is the same, but done differently. So SCBT and autogenic drainage are those that are known as modern techniques, okay? They are the ones that are known as modern techniques, and they work to achieve the same goal, but done differently. Here, we are saying there is sticking, okay, and sticking. So if you see from the normal tidal volume here, okay, from the normal tidal volume, there is breathing out from the expiratory reserve volume here. That is where most of the breathing is happening, so that you unstick, breathing out. You're trying to push the air up. Okay, again, unstick. Then you go into the second phase where now you do a lot of breathing out, pushing up, forceful breathing out, so that there is collection of air into the central zone. into the central zones, pushing up of air into the central zones. Then at the end of the day, half, so that now the air all goes out. So that is what is referred to as autogenic drainage. So I was explaining using this diagram, and the detailed explanation is on the notes on the side, which are actually which are basically talking about the same. Okay, so we said the third one now is what is referred to as the instrumental techniques, where instruments are used which are non-invasive, okay, and are considered useful for this purpose. They are used to support or even to actually achieve the same goals that we have already discussed. Common instrumental techniques used, they are those instruments that produce positive expiratory pressure, okay? There are various positive expiratory pressure devices that can provide resistance to the expiration from the mouth through the mouthpiece or face mask, followed by forced expiratory techniques. Okay, so what we are trying to say is there are a lot of these instruments that work to achieve the same goal. So the physiology of achieving this is almost the same and only done differently. But at the end of the day, the goal is the same. So you do traditional methods, modern methods, the basic the basic mechanism is just the same. It's only the application which is different. So depending on what works for you, then you can use. If you have equipment where you're working from, you can use equipment. It will result in the same way. These devices will include devices such as the flutter, a cappella, lung flute, among others. Others offer continuous positive airway pressure. Okay. There are also equipment that use positive airway pressure, which will include inspiratory tubing as well as expiratory tubing, immersed underwater in an underwater bottle, and a bubble CPAP. So there are quite a number of those instruments that work on this kind of techniques. So these instruments here are highlighted, and we are just highlighting them like this so that you can actually research further on each one of them and get to understand how each one of them is and what mechanism each one of them uses. Otherwise, there are a number of them. Others are known as high frequency chest wall oscillation, okay, in which an external chest wall oscillation are applied to the chest using an inflatable vest that wraps around the chest. These machines produce vibrations at variable frequencies and intensities, helping to loosen the thin helping to loosen and thin mucus and separate it from the airways. So it is actually what we have already discussed. They are just different applications and coming in differently. So each one of them has a different way of doing it. There is also what is known as intrapulmonary percussive ventilation, okay, in which all of these are done, which also incorporates the nebulizer for the delivery of aerosol, okay, under the intrapulmonary percussion pressure. Okay, so that is about the instrumental techniques. Importantly, also, breathing control is important. Patient needs to learn how to control their breathing. Remember, we talked about a number of indications, which included the number of indications which included surgery. So the patient needs to know how to control their breath so that they achieve these goals without any problems. Okay, so under breathing control, diaphragmatic breathing is emphasized. You tell your patient to sit upright like we can see in the picture there. I mean, to sit on a chair like we can see in the picture there. Okay, tell them to hold their lower abdomen and take in breath, breathing gently through the nose. Feel your abdomen expand as the air flows into the lungs. Okay, breathe in, hold as they are feeling the hand movement, then out, which is referred to as diaphragmatic breathing. Can be used when the patient is feeling breathless, as well as any other interventions. Relaxation is also important to be taught. Okay, a physiotherapist may use different positions to ease breathlessness, and these positions are also helpful when a client experiences a shortness of breath during activity, exacerbations of respiratory disease due to adverse weather conditions, or when they feel anxious and need to relax. These positions optimize the use of the diaphragm and encourage relaxation of the shoulders, arms, and the upper chest. The diaphragm is the primary muscle of respiration. So everything that we are doing about respiration have to border on it. Okay, so these positions include the positions that we can see on the picture here, of which their description are on the side. So the patient can be in high side lying, which is as we can see on the picture there, or they can be in forward lean position, which is there you give them the pillow and relax like that. Forward lean sitting at the edge of the bed and leaning against the wall while standing. So depending on the situation in which you are found, this can be done at whichever point. Okay, whether there is nowhere to stand, you can, where there is no seat for them to sit, you can still improvise and tell them to stand that way while leaning somewhere. Or if there is no chair, they can sit on the bed and also sit like that. This will help them to achieve the same goal, where they will relax and the diaphragm will be able to operate as normal. So these are some positions also that have been emphasized that we are emphasizing in this discussion. Okay, and these will promote relaxation and actually achieve what you wanted to achieve. Thank you so much for listening. We'll meet in the next lecture.